Good morning, everyone, and afternoon to some of those on the East Coast. My name is Kim Ellsbury. I'm the Vice President in AMN Healthcare's Workforce Technology Solutions Group, which includes our virtual care platform, Cinzy. Cinzy provides virtual care and remote patient monitoring platforms in the post-acute market, including home health and hospice. I will be your moderator for today's exclusive discussion on how remote patient monitoring, or RPM, reduces rehospitalizations and enhances outcomes and satisfaction. Today's virtual event is being recorded, and the recording will be sent to everyone after the presentation. All participants are muted. If you have a question, please use the Q&A tool in this webinar platform, and we will respond to the questions at the end of this session. Our esteemed featured guest today is Bo Sorensen, Chief Operating Officer of First Choice Home Health and Hospice. Bo, thank you so much for joining us. Can you give us a brief overview of your professional background, as well as tell us about First Choice?
Yeah, absolutely. So I have been in home health and hospice since 1996. I know that it may not look like I've been in the industry that long, but I've been here pretty much my entire professional career. I've done all kinds of different office work, from auditing, payroll, accounts payable, and then into some more I would say higher level things like running the finance department, running our operations, running our IT department. And then working through to eventually administrator, CFO, and COO roles. And First Choice, we are a organization in Utah. We have been around since 1996 as well. And I was not the COO of First Choice in '96. I was just a part-time employee in home health at the time. But we got into first home health, and then we did hospice in 2005. And we currently cover an area called the Wasatch Front that is about a 3,200 square mile area where the bulk of Utah's population lives. We have won quite a few awards for our technological innovation. We were among the first agencies to get a fully electronic medical record. We were early adopters of what telehealth used to be. It's certainly changed since then, but we did adopt some platforms early back then. And we got all of our clinicians on electronic devices in the early 2000s, back when people were using Palm Pilots. So we've really looked a lot at technology on how we can better serve our patients and improve the experience in home health and in hospice. We do a lot of stuff with wound care, with cardiac care, and a lot of orthopedic work with our clinicians. And we have a lot of employees who do their job day in, day out, and do everything they can to make sure that our patients are taken well care of. So we love what we do, and we love seeing how we can make a big difference in people's lives.
Wonderful. Well, thanks, Bo. Just to set up today's session, we're going to discuss several topics about telehealth, remote patient monitoring, get Bo's insights into those, talk about delivery of patient care and outcomes, and how using virtual care is important. For remote patient monitoring, we're going to discuss selection process, implementation, adoption, experience by both clinicians, the agency, and patients. And then we're going to move directly into the outcomes that First Choice achieved by using remote patient monitoring. Bo is also going to provide some insights, lessons, and tips into virtual care. And then for the last topic, we're going to dive and lean into Bo's advocacy and experience in both the state of Utah as well as on Capitol Hill. So Bo, let's go ahead and get started.
Sounds good.
Awesome. So my first question is, your mission at First Choice is really to preserve health and improve human life. How does utilizing telehealth and virtual care strengthen your mission?
One of the things that we look at is, we know that there's a lot of time where we're not in somebody's home. It may be that they are, we only have somebody in once a day, or maybe they're only in a few times a week. And we, especially when you look at insurance companies, they're certainly not going to pay for round-the-clock care. That can be really expensive. And so there's a big block of time where we don't know what's going on with the patient. And as we look at that, we say, we aren't getting, we don't know what we can do to make those outcomes better without being more intervening, getting in there, finding out what's happening with the patient. And that's really where telehealth and virtual care come into it, because we don't have to have a body in the patient's home at all times. We can have equipment in there. We can have, be it a blood pressure monitor, maybe a SaO2 monitor, a scale, all of the different RPM pieces. And those can, if a patient says, hey, I'm not feeling so well, they can hop on a quick virtual visit, connect with a clinician, and have that be a nice face-to-face interaction, as opposed to I'm just talking to somebody over the phone. The clinician can see the patient's skin, their tone, and make an assessment. They can also say, let's put on some of this equipment that you've got, take some quick readings, and have that then run into the chart. The nice thing about that is that then, let's say that nothing happened, we were able to resolve whatever concerns they had or crisis they may have had, keep them out of the hospital. Then the clinicians following up are able to continue to say, here's what's going on with the patient. I saw that there was this issue. Here were the readings, and let's monitor that more closely. So it helps us to maintain that quality of care and keep them in their homes, keep them more independent, while at the same time reducing the overall cost of care, because we don't have to have somebody in there as often. And that's really what we looked at and said, by doing this, will it improve their life? Will it preserve and heal them? And we said, yes, this will. This absolutely will do that. So that's what we looked at, and we said, this fits with our mission. This does what we want. And so let's move forward and let's make this a successful program.
And, in your opening, you talked about really the importance of leveraging technology and getting your clinicians to adopt it early on when others weren't even thinking about it, really. Tell us a little bit about the early days and what it was like, and how do you think it really positions yourself now for, I would call it, the modernization of using remote patient monitoring and virtual care?
Well, I'll tell you, the early days, I would say it's rough, and it was, but it was also less rough than the alternative, is what we said. We looked at, the challenges with paperwork and documentation and being able to document to a chart. And that was really challenging when, you'd have clinicians walk around with binders full of information, because, you might have an on-call clinician who is taking care of 100 different patients, and that group of 100 patients, either they didn't know what was going on, or they had a massive stack of paperwork that they had to try to filter through if something was going on with that patient. By getting that digitized, even as imperfectly, compared to today as it was, where it was a subset of information, it was on a small screen. The nice thing about it was that it got that information into more people's hands, and so they were able to take care of the patients in a better way. And furthermore, it was on top of being able to take care of those patients and get all of that information more accurately, it reduced their burden overall as a clinician. And we looked at that and said, okay, as we go forward with technology, we want to always look at this in mind. Is it going to reduce the burden on the clinician? Is it going to give information, more information, better information to the clinician so they can make the right decision? Because you look at home health and hospice, and we're at a big disadvantage in terms of information relative to a hospital or relative to a skilled nursing facility, because we have all of this information, it's all disconnected. Our clinicians are running around large geographic areas and often don't see each other. And so it's not as easy to get together and communicate and put hands on somebody like you would if you're in a facility. And so anything we can do with technology that can make that happen, we say that's worthwhile and that's worth investing in it. So that's where, really moving forward to the next generation of telehealth products, like we did with Cinzy, makes sense, because it helps to bring more of that hospital level. I don't want to say hospital experience, because that's not always a great experience, but certainly that hospital level of care into the home, where we can have more information and make better decisions and better coordination between the entire care team. You're on mute, Kim.
Thank you. It has to happen at least once during a presentation. There's so many questions I want to ask you, especially about clinicians and clinician adoption. When you were thinking about partnering with Cinzy, what were you thinking as far as your experience needed to be regarding clinician adoption, the implementation, the ease of use? Can you talk a little bit about that?
Yeah, definitely. One of the things that we look at with everything that we do, this wasn't just with Cinzy, but too often with, and this is an experience not just unique to home health, not unique to healthcare. This is an experience across every technology vertical. It's across every company in the world. Is you get a lot of technology companies coming in and saying, hey, look at this great thing that's going to impact your life and make things better. And you might say, hey, this is great, let's buy it. And it may be the greatest thing in the world. The problem is that once you buy the greatest thing in the world, you have to implement the greatest thing in the world. And too often companies spend a lot of money on technology or on equipment or on anything, and then they put it on a shelf and think, I'll get to this when I can get to it. And that was something that we said we don't want to do. We don't want to go into this and say, we've got a great new telehealth product, we've got this awesome RPM solution, and then let it sit on a shelf and gather dust and not help anybody. Because while it might help Cinzy because we're paying them money, it certainly doesn't help us because we're not seeing any return on our investment, and it doesn't help our patients because they're in the same situation that they were in. So we said, we've got to have somebody who will help us get this implemented, who is the right fit, and that is easy enough to use for us, for our clinicians, and for our patients, that we can influence that adoption and make sure that people actually say, this is something that I want to use, as opposed to this is something that I have to use, or that is being forced on me. And then, too often when it's not something that is your primary, if it's an EMR, you're going to use it whether you like it or not. But with something like telehealth, it can be something where your clinicians say, you know what, I'm not going to use this. This isn't worth my time. And just let it sit on a shelf while you think, this is great. I've got this great telehealth program. Look at how wonderful we are. And you find that nobody's ever used it. So that was what we were trying to avoid. And that was something that, as we looked at different vendors, we said, who can help us to get that adoption, and who will support us, not just when we purchase and not just even on implementation, but throughout that whole life cycle, so that we're making sure we get the right care and the right information and the right platform in people's hands.
What about patients? How do patients fare with the technology and the use? Do they like it? Just talk a little bit about it.
It totally depends. We've got patients who are all the way from 19 years old to 99 years old. And you'd think that maybe, well, because their ages are, the 19-year-old, he's going to totally be okay with it. But that 99-year-old, man, he's not going to have a good time with this. But that's not necessarily the case. You've got some people who are really, really interested, and they may have a little bit of a hard time with technology, but they're wanting to do it. They like it. And I think especially with the pandemic, we've got so many people who are starting to use technology in a different way. I mean, here we are on a Zoom call, and it's not much different from what a lot of our patients had with their families, because they're in facilities, and the facilities were locked down, and it was the only way they could see their grandkids. And so that helps to drive interest and drive the learning of our patients, so that they actually got on board with some of this technology. And the interface of Cinzy is super simple. It's not like it's a hard thing to learn. So that was one of the things that was really important to us, is we didn't want to have patients who would come back and say, you know what, this is really challenging. Tell me how to use this so that then I can turn around and make a video call. It needed to be, I'm going to make the video call and I'm going to do it right now because I know how to do it. So, and that was one of the great things that we saw, is that it was easy. You download the app, you connect, and it's, while it's a little more complicated than download connect, it's not that much more complicated. And if you can do a Zoom call, or if you can do a FaceTime call, you can do a Cincy telehealth visit.
Great. Well, your organization has had a significant reduction in hospitalizations. You went from 11.6% to 4.8%. I'm going to say that again, 11.6% to 4.8% by utilizing remote patient monitoring. I mean, congratulations. That's a big decrease and an improvement. You know, what are some key insights that you've learned from this, and what are you going to do in the future regarding virtual care? Like what's next, and how should people be thinking about this?
Yeah, for sure. I think that one of the things that we learned first, and we learned this a few years ago too, and is that you always need to have information. You need to know why your patients are going to the hospital. And we had a higher hospitalization rate than 11%, and we were able to, you know, we were, I think, somewhere in the high teens. We looked at it and we said, okay, what is causing all these hospitalizations? And we drilled down on every single one, and didn't just say, okay, well, you know, they went because it was this. We said, who's the clinician that sent them? We said, what was the time that they were sent? What was the diagnosis? Why did they get sent? And we did that, and we're able to significantly reduce our hospitalizations. We did that again right around the time that we were looking at a new telehealth platform, and we said, what was the times? What are the causes? Who are the clinicians? And one of the things we found is that most of our people were going to the hospital after hours. So it was people who are not being seen by our regular clinicians. Our hospitalizations there were really, really solid. It was people who were being directed there maybe by our on-call clinicians because they didn't have the ability to get the information that they needed to make a good diagnosis. It might have been that the patients didn't feel like they could contact our on-call clinicians, or they weren't able to get them in time, or they didn't want to do a phone call. They thought that wouldn't be helpful. So they just said, well, I'll go to the ER. And that was really what was driving our hospitalization rate, was that after hours stuff. And so we said, okay, because after hours is our issue, that's where we need to focus our energy. And that energy really got focused around how can we give better tools to our on-call clinicians so they can make a diagnosis, so they can call doctors or get information that's needed, resolve concerns, check vitals, so that if the patient does need to go to the hospital, they can still send them. But if they don't, then they can keep them in their home and then maybe redirect them to a clinician during the daytime hours, or alternatively, they can also go out like they would traditionally do that. So as we did this process, we said, okay, we're going to get telehealth into their hands first, into our on-call hands first. Let's not worry about our daily staff. Let's let them continue to do what they do, but let's get our on-call clinicians trained and focused in on this so that they can make better decisions. And that's really what we saw drive our reduction in rehospitalization. So those after hours hospitalizations dropped in half, which, while we had some other rehospitalization drops as well, nothing was nearly as dramatic. And because most of our hospitalizations were driving those after hours clinicians, that helped in turn to reduce the number of rehospitalizations overall. So there were a couple other things, but in general, I would say that the impact of RPM, the impact of these telehealth visits on those after hours rehospitalizations was really, really dramatic, to the point that, you know, of that 11.6 to 4.8%, you could probably say that 70 to 75% of that reduction was directly related to those decisions to drive telehealth through our after hours clinicians.
Great. Well, you've shared a lot. What other tips or learnings do you think it's important for people on the phone to know as they're looking at remote patient monitoring solutions? And maybe also talk a little bit about how the COVID pandemic has really accelerated the adoption of the technology.
Yeah. One of the things that I would say is that while I know that we are on a Cincy call today, is make sure that you choose the solution that works best for your company. And while I think that Cincy is a great solution, and we evaluated multiple different vendors, we looked at them and said they're the right fit for us. And they may not be the right fit for you. And if they're not, then that's okay. But don't just go into one and say we're locked into this one vendor. Look at, not just price too. I mean, price is certainly a key component, but also look at performance and look at ease of use, and look at what they connect with. Sometimes it may look like you've got all the peripherals in the world and you can just grab stuff off the shelf and no worries. You can source your RPM in stuff out from anywhere, but that's not always the case. It's not quite as easy as that. So check and make sure that you have an end-to-end plan and how it's going to roll out and who you're going to roll out with. And then once you roll out, once you actually choose somebody with RPM, then say, how are we going to get this into the clinician's hands? And use some of your clinicians. The people that are going to be using it the most are not your administrators. It's not your IT people. It's the people who are actually in the field or who are your on-call staff who are going to be using this. And so get their opinions, because ultimately they're going to be the ones adopting it, not you. And if you can't get that adoption from them, then you've bought a really lovely, really nice piece of shelfware that will not do you any good and will not do your patients any good. So make sure that you're doing that. And also, just in terms of the pandemic and how that's accelerated things, telehealth is far more accepted now than it was 18 months ago. And there's real energy, not just from doctors or hospitals, but from Congress and from patients to start utilizing telehealth more. I know that, just from a company standpoint, we were utilizing a version of telehealth for all of our staff as part of our healthcare program. And they would call in, get a doctor, they could get prescriptions over the phone. And it was not nearly as robust as the telehealth and RPM solutions that we have in home health. But it was still something that reduced our overall spend. So it's something that I think that has been proven now through these past 18 months that it does reduce the costs. Insurance companies are going to continue to be interested in it. The government's going to be interested in it. Patients are interested in it. Now is the time to strike and to set yourself apart and say, we do telehealth and we can take care of you end to end. We don't need to pass you off to somebody else. We can really drive your care through us. And we as home health and hospice agencies are designed to do that. We're designed to take care of people who are in different living situations, who are not connected to a facility, and who are, sometimes pediatric all the way up to geriatric. And we, because of all that experience that we've built over the past 40 years in the industry, if we position ourselves right, we can really be in the driver's seat in the future of healthcare. And that's the kind of thing that I think really will drive home health and hospice forward over the next 10 to 20 years, is the shift to telehealth and the shift to, especially with technology that we have just on our bodies now. I mean, I don't have any implants, but I do have an Apple Watch, and my watch takes all of my vital signs. Other than blood pressure, it lets me know what my pulse is, what my pulse ox is. It lets me know if I'm having problems. It lets me know about my gait. And all of that is stuff that matters to our patients. It is stuff that can keep them out of the hospital. And it is stuff that can get integrated into telehealth. And maybe it's not all there yet, but it certainly will be. And as we utilize these data sources that people are starting to put on their bodies, we can have a better view of what's going on with them. And that better view will lead to better care, lower cost care that will really position us as the center of healthcare in the future.
Wow. Thank you, Bo. Anything else you'd like to add as part of your advocacy, both in the state of Utah or Capitol Hill? Anything that people would be really interested in hearing?
Yeah, one thing is that I've talked with several, I've talked with our governor here. I've talked with representatives and senators from our state, and they are all really, really interested, not just in telehealth, but in home health telehealth, in hospice telehealth, in our industry being positioned as one of the centerpieces of healthcare. And that is a big shift from how things have been throughout most of my career. Usually it seems like home health and hospice were kind of an afterthought. It's like, well, we got the doctors, we got the hospitals, and that's where most of the money still is going. But that's not where most of the attention is going. They're saying, how can we take care of people at home? We've got the ability potentially to do, with these new bills that are up for consideration. There's hospital at home, there's skilled nursing facility at home, and that is the kind of thing that it causes the other provider sectors to be a little bit afraid of us, because we are positioned to do that and they are not. Sure, they have fancy equipment, but they also have fancy buildings, and those buildings cost a lot of money. And so in order for them to cover their costs, they have to charge higher rates. We don't have to do that because we're not housing anybody. And so as a result, they are looking at us and saying, you know what, you are low cost relative to all other sectors of healthcare. You are high quality. And that's one of the things to consider with value-based purchasing. I know that a lot of the home health agencies that are out here are saying, I hope that value-based purchasing is going to be good for us. We should take value-based purchasing as a real vote of confidence for home health. It is the only value-based purchasing concept that actually saved money for the government. Nobody else's did, just home health and hospice. And that speaks to A, the quality of our care, and B, the value of our care, because we reduced hospitalizations, we improved outcomes, and we are well positioned to be exactly where we need to be for this. And so, everybody on Capitol Hill is saying, this is good. We like the concept. We like the idea. We don't necessarily know the mechanism in order to fund it yet. And in order to, and that's one of the problems with telehealth is we've seen remote patient monitoring, with the prior generation of telehealth, just remote patient monitoring be something that could be a benefit, but they say, we don't know how to fund this. And so you have to pay for it yourself. Now with telehealth, with the video capabilities that have been brought about by technological advances, we have, I think, a little bit better way for them to say, here's how we can pay for it. This is more like a visit. You've actually got face-to-face interaction. And now we just need to decide, how can we do this? And so that right there is what they're looking at, and they need our help to tell them how to do this. How is it that a video visit should be counted? Should it be a quarter, should it be a visit equivalency of some sort, maybe a quarter, half, 3/4, or full? Should it be something where you get an additional supplement for people who are on telehealth, and they give you a bonus for that? Is it something that it should just be a straight per visit type of model where they pay you extra for each virtual visit that you do? There's a lot of different options out there, and I haven't decided what the best is, and Congress certainly hasn't either. But that's where we come in, is we need to be advocates for this, and we need to be advocates for our industry to say, we can do this. We can be the skilled nursing facility. We can be the hospital. We can be telehealth. We can be all of these things, and we can do it better and cheaper than anybody else. And we've proven that, and we will continue to prove that. And that is why CMS is giving us value-based purchasing, because they know it. And now we need you to help them to provide the funding for this next generation of home health and hospice, because we're just in a wonderful position right now. And I'm really looking forward to the future. It's the most exciting time that I have seen in the whole time that I've been in the industry. And, that's what, 25 years now. So it's very, very exciting right now. I'm really happy for what's going on.
Great. Well, thank you, Bo. I appreciate the conversation and you sharing your experience regarding remote patient monitoring, your journey through the last couple of decades regarding technology. And so we're going to go now and answer any questions. I know we have a few in the queue right now. So Bo, the first question is, it's a common stigma that the elderly population will not embrace technology. Can you speak more to your experience with patients engaging and utilizing remote patient monitoring technology?
Yeah, that is definitely a stigma, and it's a stigma that has basis in fact. And a lot of that is because technology is harder for you as you age. Your brain can't catch up to all of the advances that are being made. And technology is just changing so fast right now. But one of the things that I think has changed that, and that is making it easier to adopt telehealth, is it's really hard. Everybody has a cell phone now. There's very few people who don't. And of all those people who have a cell phone, roughly 90% of cell phones nowadays are smartphones. So they're using some kind of technology that already makes their life, makes it so that they are doing something to learn it. And old people are not just saying, well, I'm going to use this as a big phone that has a fancy screen and that's it. They are figuring out, with their kids, saying, hey, I'd like to see you guys more. And the kids say, well, we've got this thing called FaceTime, or we've got Zoom, and here's this app for that. And so they're starting to get more used to, here is what is going on with technology. And that's something that we've really seen transition over the past 5 years. Our patients, I would say, from 2000 to roughly 2012, 2013, were very, very slow on catching up to technology. They didn't have email. They didn't have a smartphone. Certainly, they were still using older style phones. They maybe didn't even have a cell phone. They just had a landline. However, the change over the past 5 years has been pretty dramatic, where all of our patients now have smartphones. There are very few that we go out to and we say, hey, can we put this Cincy app on your phone? And they say, I don't have a phone. There's practically none. And so as a result, they are already primed to know how to download apps. They're primed to know how to do video calls. And just with a little bit of coaching on that first visit, when you come in and you say, okay, let's get you set up with Cincy, it really is a matter of them trying it out, clicking the call button and saying, okay, that wasn't so hard now, and moving forward with it. It is a very simple process to engage our patients now, as long as, I wouldn't just send them off and say, okay, download this on your own and figure it out. I do like to have somebody go out there on that first visit and teach them how to use it. But once you give them 1 or 2 test calls, then they're good to go.
Great. You talked about how important it is to have the clinicians involved in the process, in the technology. A lot of concerns that I hear from my clients are that clinicians are strapped for time. Efficiency is important. How do you circumvent that? How do you get them excited? How do you carve out that time for the clinicians? What does that look like?
Certainly with our on-call clinicians, it was easier than with our regular clinicians, because for them, the sales pitch is, hey, do you guys not want to have to get up at 2 a.m. and then drive a half an hour to a patient's house, take care of them, and then drive a half an hour home? Would you like to get rid of that drive time and maybe even get rid of a lot of that visit time just by getting a call and talking with them on the phone? And so that was an easy sell. They saw the value add on their end pretty quickly. For our other clinicians, part of what we do is we try to incentivize them to give better care. It's not just about pumping out visits, although that is certainly, one of the key metrics that everybody looks at is how many visits is it that you're doing, that you're getting taken care of in any day. But we also try to say, what are your outcomes from that? And we base raises off of outcomes. We base their overall, that's a key part of their overall performance indicators, and what we look at on a day-to-day basis in our agency is who is giving us the best outcomes. And if you're giving bad outcomes, then you start down a disciplinary process. And if you don't, then you might be, perfectly fine and you're just going straight ahead. But if you're really helping to improve, then you're eligible for raises and things like that. So we do try to tie that and say, here's how this can help you, because if you go out and you spend a couple of minutes teaching this patient how to download the app and how to make a call, then you will end up getting better outcomes. Those better outcomes will then give you a more likely opportunity to get raises and bonuses in the future. So that's really how we try to tie it.
Great. Well, incentives always help, and you've talked about that. The technology is fairly easy to use, and the clinicians helping the patients download it, the first visit, that is normally effective. At this time, we don't have any other questions. I do want to thank Bo for taking time out to speak to all of us. Today's session was sponsored by Cinzy. Please visit cinzy.com to learn more. You can also sign up for a custom demo. And then this concludes our Cinzy Spotlight for today.